quick word about InMedical. It's an organisation that's been providing data analytics to the NHS for just under 6 years. The organisation uses an innovative approach to providing that information. We don't just work with NHS or ex-NHS people. In our staff we have clinicians, which is pretty innovative for a data and integration company. Clinicians are at the core of everything we do, as is understanding the patient. We bring in skills from banking, from retail, and from a whole plethora of organisations and industries to help solve the NHS conundrum for NHS entities around the UK. So looking back and listening to the earlier speakers, we're very much at risk now of going back to where we were. Not so very long ago, and in an awful lot of the UK, this is the data warehouse that clinicians use to understand what patients look at. If this old lady can't remember where she's been, the drugs she's taking, maybe she's suffering from dementia, has an accident, we find out only too late that she actually can't take penicillin, having pumped her full of the stuff. This is not acceptable. This is a disaster. This is shameful. This is not something that is normal in any other industry in the UK. So why does this happen? In our experience, in my experience, this is what a current CCU has to kind of deal with on an annual basis. This is the sort of data that confuses. My goodness, with the government throwing some legal problems in the way in terms of how data can be shared, the problem becomes more complex. But what the lawyers don't understand is if this isn't solved, we go back to having the only data source available to us, which is that old lady. Now you're grabbing data and information from this is just a small CSU. This is what you're having to deal with. This is what you need to be able to deliver to every clinician, every nurse, every manager across the CSU, the CCG, in order to make sure that that old lady is not your only source of data. We'll come back to that old lady and her needs and wants a bit later, because she is very, very important. But if we actually think about that problem and then compare it outside of the NHS industry, let me give you for instance, what happens in transport. A previously government-run organisation, Transport for London, or the London Underground. These things are used by have now been issued 34 million times, and about 7 million of them are used every day. They operate across buses, across tubes, across trains, water transport, and for those of you that get them, they will even send you data to tell you when the stations that you regularly use are shut. They will send you special offers. In fact, these people collect more data and use it in an integrated way than we do in the health service. Now, that's not something to be very proud of. That Boris Johnson knows more about what's going on around London and where people are going at an individual level than we know about patients. This was solved, by the way, 11 years ago. This is old technology, so why haven't we put that in place? Well, I understand the problems and we all face them. This is where we want to be. Care plans that will improve outcomes. But the problems are, we don't have enough consultations, we're over-prescribing, we refer too much, the A&E admissions are too high, the Francis report, it goes on and on and on and on. That's the ambition. The reality is we get snowed under. Data in that scenario doesn't probably help very much. Because, you know, when the swamp is full of the good old stuff and the alligators around, you forget that you were meant to be draining the swamp. But let's face it, this is where most NHS entities find themselves. It was interesting listening to Angelo Fernandez saying, but you have to be hard. You have to make the difficult decisions about what you are going to invest in. Otherwise, we will always stay in this place. We will never get in front of ourselves. And the way to measure that, unfortunately, is money, is economics. Our economy, the government, the Treasury, the NHS has to measure things fundamentally in terms of money. And healthcare around the world, which is where we work, and we understand, we know, that what we are working with in the UK is not a single instance of overwork, of under budget, of poor economics, and of difficult circumstances. There is not enough money for the healthcare services around the world to work this way. It's not just in the UK. Now, some of the economics are also related clearly to politics. But in understanding where the money goes, where the energy goes, and understanding where we're successful, where we're not successful, you might just be able to make a difference. This is a small project working with some acute trust A&E data. I can't get down to a level of detail because we've got some governance issues here, but being able to drill down to find hotspots of admissions within the A&E departments that we looked at. When we did some postcode mapping, we found that there was hotspots of admissions in through A&E, really tightly grouped around postcodes. Take it a bit further, we found the care homes that weren't successful in those areas. It transpired, of course, that pressure, work, problems in the care homes, but also what we could do is try and encourage the local clinicians to reach out to those care homes so that the care home staff were better trained, more knowledgeable, more understanding of what their responsibilities were, and were calling the local clinicians rather than calling 999 when a 93-year-old lady, as I put up on the board earlier, was suffering from dehydration. Subsequently ended up going in as an unscheduled admission and staying in hospital for a long period of time. Now that didn't suit her, it didn't suit the hospital, it didn't suit her carers, it didn't suit the family. Strangely enough, the economics didn't suit the care home either. And of course, with the way that the structure of CCGs are now being funded, it doesn't actually suit the economics of the CCG to have that old lady admitted because it was maybe a little too problematic to ensure that she was properly hydrated. So how does data work? Well, that's one instance. That's one very simple, non-complex instance as to how to reduce expensive A&E attendance and expensive admissions in through A&E for creating bed blocking and long stay background into A&E. That's the workflow of just one instance. For those that understand the economics, what I've just described, that flow, that problem of data not being understood in its most simplest case, hydration in a care home. Data creates a disconnection, it fragments economics, it fragments workflow, and in all industries, those that I've mentioned. You know, when things go wrong at Tesco's, when that coffee jar doesn't get in the store and onto the shelf at the right place, at the right time, at the right price, it actually becomes very costly in that you have to deal with, in data terms, the 80%. You have to get that right. When you get the 80% wrong, it becomes very costly. And as I've just described, in that just one instance, we're looking at reducing attendances at A&E by just over 6% by putting people into the care homes that were not providing the level of care that was required for their community. This is a small piece of a system that we've put in place. It's now just going to run through a few things that we do. Again, it's analysing A&E data. We now take data from its socioeconomic data, postcode data, PAS, SAS, SLAM, GP systems. We're combining it to produce this analysis. This data, this system was actually produced 3 years ago, but it is still operating. It's anonymised data. You won't be able to see any patient level, but it could go down to it. As you can see, we've picked 1 month, one time between 12 and 6. We're going to look at what was actually happening in terms of who was turning up at A&E from what GP practices. Now, when you talk about data, this is real data. This is where the costs came from. I don't know if you saw, there was 23 hospitals in one CCG where they had A&E admissions across the country. Actually, throw away 20% of that, it's not relevant. Don't get stuck down with having to have all the A&E data that you need in order to make decisions. So we're now just looking at what happened when they turned up. As I say, this is real data, but anonymised. This is a real system. Did you see that? 34% of the patients that turned up in A&E just wanted guidance. That's the, I don't know where to go, can you help me? Wow, isn't it great to have spent all that time at medical school, qualifying as an A&E consultant, to be asked, where do I go to get my tax form checked? How do I get my grand's podiatrist to turn up on time? That's guidance. Unfortunately, most of those people, we find, did not need a clinician, did not need the services from A&E. But we have to ask ourselves, why were they turning up there in the first place? What was so very wrong? Why couldn't they get that information elsewhere? Those 34% are just after information and a little comfort. So now we're going to look at all the reasons that those people turned up in A&E. And as a CSU or a CCG, or even working in that acute trust, again, we're going to be looking at that slot in April between 12 and 6 in one A&E department. And we're going to be looking at what actually happens here. Laceration, and we could look at any of these areas. So we're now going to look at the treatment description for that laceration. Of 556 lacerations, 140 people were treated in A&E. They were discharged immediately, did not require a follow-up, and effectively were given a sticking plaster to go home with. You cannot tell me that that A&E department was particularly chuffed about that one either. Now we look at, again, a little bit of where do they come from? If you look at those numbers, the percentage, strangely enough, and this is a real instance, 24% of those came from one surgery. They were registered at one doctor's surgery. Again, if we're looking at making a change, we're not looking at making massive change, because in fact, I think the law is not going to bend too much towards allowing us to make the massive changes that we need. But what the law is going to allow us to do is to look and find those individual patients and look at that GP surgery, and with its CCG colleagues and its CSU, say to that surgery, guys, what's going on? Why is so many of your patients turning up in A&E for wound closure? Can't we get something to work here? Or is it just that you've got every rugby club in your area registered at that GP surgeries, and on a Monday morning they're coming in with cuts and bruises for whatever? Now, there's always the other side of data, but at least it gives us somewhere to look. And that you've just seen is not complex analysis. As I say, we were doing that stuff 4 years ago. That was in place, is in place, and is still in place, being used by the GPs, by the hospitals to do that analysis. We've got some really amazing stuff. But actually, we've got some really amazing stuff. I'd love to sell you all loads of it. But actually, when it comes down to it, that data is probably all you need to start with to make a massive difference to what you're doing. Elastoplasts, hydration, postcode analysis, looking at where people arrive in A&E. Goodness, this is not difficult stuff at the moment. I could draw this, by the way, this map of fragmentation, encapsulation, and then interrogation sits with any industry. I could be giving that slide, talking that about retail, banking, anything that involves data, and the world involves data. It's no difference, it's no change. That's why we look to, in our organisation, to bring specialists from other industries who have seen this all before. We've got a guy who works in investment bank, who was an investment banker running big data centres and data information, looks at the NHS data problem, looks at what's processed by a CSU on a monthly basis and said, that was about 30 seconds worth of trading around the world that we used to look at. This data thing's not a problem in the NHS. It never is a problem. It's a question of the change management and making things happen. And understanding where those easy wins are to create the benefits of economics so that investment can be made behind that to ever increase the level of information, analytics, data and clinical outcome information that the clinicians that you all need. So we'll come back to the individual. As you've seen, 50% of us are going to die. No, we're all going to die, but 50% of us are going to die in the wrong place. Well, we don't want to die. We're going to consume 60 to 75% of the NHS budget in that process. It's going to affect 18 million people. That's the people, at any one stage, that's the people dying in the wrong place, and all of their carers and all of their family, and expend all of that budget. Now, that's what we all want. So, do we need to pay attention to what individuals want when we're looking at mass data? Well, I think you do. I think you do because the NHS, like every other organisation and every other health service around the world, is going to have to become more competitive, and the competition and the rights to competition and the rewards for successful competition are going to be funding and money. It's very clear, if you look at any industry, providers drop out over time as it becomes more competitive. And it's only those that are efficient, successful, and deliver what the customer or the patient wants that are going to survive. So how are you going to survive? How is, more importantly, maybe, how is the NHS going to survive? And looking at some of the things that are happening in our industry, you have to ask yourself the question, have we been put on a roadmap for non-survival? Maybe we need to ask the question another way. How do we ensure that patients still come first, that NHS services are free at the point of delivery, and I use that quote in its correct non-political format that doesn't give ministers the get out later on. So how do we ensure that that happens? Do we actually listen to the individual patient? Because if we did, it would make a massive difference to them, and it would be what the end users want, what the customer wants. I often hear, we need to give patients what they need rather than what they want. And I add a little bit to that and say, or what others, clinicians, feel is the right thing for them. Wow, that is just too difficult to do. You can't build a system based on that. You've got too many wants, too many needs, too many people working against each other. But remember that statistic, 50% of us don't want to die in hospital. It will affect 18 million people at any one stage in the UK because we're not getting, Grand's not getting, I'm not getting, our care for ones are not getting what they want, and it exhausts the NHS between 60 and 75% of the budget because we don't give people what they want. So that's going to be too difficult. So, in the stage that we see the NHS and NHS entities at the moment, they have to consider where they're going to spend their money, where you are going to spend your money, because you can't spend it everywhere, because you have to make huge efficiencies in a very short period of time. But where you are on a data curve and data analysis is actually really good, because those that use data and spot the opportunities, the low-hanging fruit that get there first, will be able to make the savings. They will be able to generate the savings, generate the efficiencies, and move always closer towards giving the patients what they want and providing the clinicians with the resources they need to do that. Those that are prepared to stand behind the bureaucratic boulder or boulders that are put in their ways and not make change, as organisations, will not survive. Data, as I've seen it, my company's seen it, my people working with us have seen it, is never perfect. It just isn't perfect. It never will be. Even Tesco's will admit that they don't know exactly where each jar of coffee goes and how quickly it takes to be consumed. But I'll leave you with one further thought. This comes from the guy that's meant to, or probably did, design the first computer. Big old clunky thing back in about 1880. You can see it working in the Science Museum. I like this because this is what I preach, this is what I talk about. You will never get data right. You'll never get analysis right. You will never have all the information you need. But it should never stop you making the decision. But you should be making decisions based on the data that you have, because at least then you'll be better and in a better place to serve your patients, serve the public, than having no data at all. So push for change, but it doesn't have to be perfect. Thank you.
Thank you very much. We have time for a few questions. Is anybody ready to ask one right at the beginning? Put your hands up and we've got a mic coming around to you. Anybody want to kick off? One right at the back there.
I'm from CCG down in Kent. I was interested in your original scenario around the Oyster card. But what I didn't get a sense of as you went through the presentation, whether in fact you've developed a system of actively tracking patients through the system using live data rather than retrospectively. Because clearly one of the challenges for commissioners is how do we know we've actually made a difference, and actually spending and looking retrospectively 2 or 3 months previous actually doesn't tell us a great deal of what's going on at the moment. So I just wanted to explore that a bit further.
Yeah, you're absolutely right. Using current data is absolutely essential. We do have systems that bring in current data, analyse it in real time. Even as I speak, we have systems that are analysing currently hourly PAS data and supplying that to GPs so they can see where their patients are flowing through the systems, and looking at the current data that's available, looking at prescribing, looking at where those patient flows and how patients are breaking in or breaking out of the system, and the economic impact of all of those, if you like, outcomes or those data flows. So they are available, and we do provide them, and they are out there.
Other questions? You've got your time, I forgot. Anybody else want to ask anything? Can I just ask you, we talked earlier about the difficulty with the information governance fiasco. Have you got any words that you want to say about that? Because that's key to this. Because we can't amalgamate unless we can get access. You've got your time.
Okay, I think what I was trying to show today was that the utopia of having totally integrated data has been sort of chopped off, or at least knocked over, by the realization that patient identifiable data has some legal ramifications and government ramifications around that. But hospitals, GPs, GP surgeries can still look at that data and make a difference and make a change. And as you saw, the information is there to make massive changes. Don't think that you need the perfect level of data in order to implement the analysis and make the changes. Paralysis at the moment is just not going to be the right course of action. Any data, as you saw on the screen, just analysing what came into an A&E department gives clinicians in the A&E department, gives managers, gives GPs the opportunity to put clinical decisions and clinical pathway decisions and strategies in place to manage some of those areas. Yes, it's frustrating. Of course it's frustrating not to see the overall picture. But just being able to do something that in these instances make a big difference and are available now. They can be installed in a matter of weeks. More sophisticated than I was showing you there. That product has been out there for 4 years. So you shouldn't feel that just because the information and the data is not 100% complete, that it's not going to work. Imperfect data is always the case. Changing and working towards perfection is what we need to look for.
Thank you so much, Peter. It's been a good session. There's a lot to take away here, and I'm sure that we're all aware that we have to need